I warmly welcome everyone tonight to the Respiratory Health Virtual Forum for GPs, which is a partnership event which has been facilitated by the Western New South Wales Primary Health Network and the Western New South Wales LHD. I want to thank specifically David Peebles, who's the District Chronic Care Coordinator for the LHD, for his contribution in coordinating, in fact, really initiating the planning of this event. Thank you, David. Next, I'd like to acknowledge the people of the Wiradjuri Nation and the different nations on which each of our participants meet tonight. I'd like to acknowledge and pay respect to elders past, present, future and emerging, and acknowledge their continuing connection to land, water, culture and community. We're committed to working in a spirit of partnership and collaboration with our region's Aboriginal communities to improve their health, emotional and social wellbeing. And I warmly welcome any Aboriginal and Torres Strait Islander Australians who are present tonight. So we are very fortunate. We have a great program. Three big topics are going to be discussed. Severe asthma management. Charles Prabhakar will be presenting on that. Early screening and diagnosis of lung cancer, presented by Dr. KV Singh, and we're discussing sleep studies with Dr. Henry Ainge-Allen. So if I think everyone's familiar with the side panel, just reminding everybody that you're on mute. We've got actually a lot of presentations to go through. We're going to keep our questions to the end of our session tonight, and we'll endeavour to answer as many of those questions that are possible. So place your questions towards the end of tonight's session in the question box, and we'll deal with as many of those as we can. And I think really now it's probably time to introduce Charles Prabhakar, who's one of the two local respiratory physicians based in Dubbo, and he's trained at Prince Alfred and St George Hospital. He's also done study and work at the Chris O'Brien Lifehouse, and done interventional respiratory medicine at St Charles Gardner Hospital in Perth. And Charles is going to speak to us about severe asthma management. Thank you very much, Charles.
Thank you. I'm just waiting for the slide presenter invite. All right, so the first and most important thing to say is this slide was added at the last minute. You can see me here, and you can see hopefully me on the screen sporting my beautiful Chopper Charlie moustache. There's Florence Honeyball, the person responsible, the doctor responsible for the Western Cancer Centre in Dubbo, and James Collette, one of the nephrologists. And as you can see, there is my QR code for raising money for Movember. So before we go on, please all get your phones out, take a quick photo or launch the QR code, and donate money for Movember and Men's Health. I'll give you 5 seconds. There you go, and I've got to raise a little bit more money than I've got at the moment because James is embarrassingly beating me by a lot. So what I wanted to talk about was difficult control asthma, and sort of the subtitle of it, does it really exist? And of course it exists, but I think it's rated as a much more difficult problem than it really is, or a much more common problem is probably the most important thing to say. And if we've got some drug reps online, probably grinding their teeth right now because I'm going to talk about none of their drugs. So asthma, I thought we'd just start with the definition. Asthma is a heterogeneous disease characterized by chronic airway inflammation. You get the standard sort of symptoms with it: wheeze, shortness of breath, chest tightness, and a cough that varies over time and intensity, and it has a variable expiratory flow. So at the moment, it's hard to differentiate asthma and COPD, and the most important thing about asthma, there's a degree of airway reversibility, whereas COPD is a fixed airway obstruction that can get worse, whereas asthma tends to be normal airways that get worse and then come back to normal. Difficult to treat asthma, again from the Global Initiative for Asthma, GINA. Asthma that's uncontrolled despite prescribing a medium to high dose inhaled corticosteroid with a second controller, usually a long-acting beta agonist, or with maintenance or oral corticosteroids, or that requires high dose treatment to maintain good symptom control and reduce the risk of exacerbations. So that is, once they're on high dose inhaled corticosteroids and a LABA, and they might be needing oral corticosteroids, then it's difficult to treat. So what portion of patients have difficult to treat asthma? As you can see, I've stolen this out straight out of the GINA handbook. So this is a Dutch study, and they looked at asthmatics, and they found that a quarter of the patients are on high intensity treatment. Of those patients on high intensity treatment, 17% had difficult to treat asthma, and then only 3–4% had severe asthma. And the really important point is what we're going to talk about throughout this talk is good adherence and inhaler technique, and that is critical. First thing, of course, though, is you need to confirm the diagnosis. So KT is a 22-year-old young lady. She was referred to me for exercise-induced symptoms. She was pretty fit, and in fact, she came to see me and she ran marathons, and she talked about how she could jump over creeks when she ran her cross-country marathons. She really loved running. She was on a pretty high dose of serotype, so I like converting their total cumulative dose of inhaled corticosteroid into a single number. So she was on 1 milligram of fluticasone, so that's a pretty high dose of inhaled corticosteroids. I suspect a lot of your patients are on very similar doses, and maybe you need to be thinking about how much steroid they're taking. She was pretty unremarkable. She had a clear chest, heart sounds were normal, and she didn't have any signs of allergic rhinitis. And again, remember, asthma being an atopic disease, I was looking for other signs of atopy. So first of all, I thought, well, given her normal spirometry loop there, I thought, are we dealing with asthma? Her symptoms and history really weren't consistent, apart from that she got a bit short of breath at very high exercise intensity. She didn't have exacerbations between these times. She was very well. So I stopped her puffers. A couple of weeks later, Richard organised for her to have a bronchoprovocation challenge, which was negative. Over the same period of time, she kept a peak flow diary. So I just asked them to do it once in the morning, and then if they used their Ventolin, to do it before and after their Ventolin. And her peak flow diary was flat. And in fact, I gave a diagnosis of vocal cord dysfunction. I saw her one more time. We kept her off all her inhalers. She keeps a Ventolin as for reassurance in her house, but she confessed to me that in fact she didn't have any more episodes, and she went to see the speech pathologist and did some voice retraining. So you need to confirm the diagnosis. So I pretty much, for all my patients that I get to come in to see for asthma, if I'm not confident with their symptom history, to give them a clinical diagnosis, a very classic asthma history, and even some of those that do, I will stop their inhalers and get them to see Richard with off their inhalers for pre and post testing to demonstrate that there is a degree of airway inflammation and reversibility. I get them often to keep a peak flow diary as they withdraw their inhalers, especially if they're a bit nervous about withdrawing their inhalers, because this gives them some degree of reassurance. They can see that they're not deteriorating. They may feel more short of breath, but if they've got a stable peak flow diary, then they know they're safe. I tend to get a chest x-ray looking for other asthma mimics, such as bronchiectasis, and I think about their comorbidities. So this patient illustrates the point. So she's a 41-year-old lady. She referred to me for unstable asthma during pregnancy. And in fact, she didn't get asthma between her pregnancies, although she was on an inhaler at the time. She just got it during her pregnancies. She had been on beclomethasone prior to her pregnancy, and due to unstable symptoms, she'd gone from about 200 micrograms of QVAR, one puff twice daily, up to 200 micrograms of fluticasone furoate, which is, again, a significant increase in inhaled corticosteroids, plus the addition of whatever the bronchodilator is in Brio, Vilantrol. and she still had active symptoms. She gave a history of asthma, childhood asthma, which she grew out and then returned in pregnancy 1 and then pregnancy 2. She was an anti-vaxxer, and it was very difficult to talk to her. She was a light ex-smoker, depression, again, no allergic rhinitis symptoms. So again, I'm thinking, are we not dealing with asthma? And then asking closed questions about other asthma mimics. She did admit to having quite poorly controlled reflux, with daily reflux symptoms despite the addition of PPI. It was COVID, so I just guessed that it was normal. And the only thing I could tell was that she wasn't overweight by checking her pre-pregnancy BMI, and she'd gained about the right amount of weight during her pregnancy. So my guess was that she had reflux-induced airway inflammation. She had quite severe ongoing reflux despite 20 milligrams of omeprazole, so I increased it to BD and wrote to her GP and asked her to consider increasing that into 40 milligrams twice daily if required, as well as adding in pre-bed Gaviscon, because she gave a fairly classic history of coughing through the night, and I suspected she was soiling her airways overnight. She did admit to having some improvements in her symptoms with the control of reflux, and what I'll do is I'll confirm whether she actually has any degree of asthma in her postpartum stage. But I've left her on her Breo Ellipta because it's a safe thing to do during pregnancy, rather than to try and prove that she does or does not have asthma during her pregnancy. But I suspect when I see her, I'll discover that she doesn't have asthma between pregnancies, and she has reflux-induced airway inflammation. So this is a list of the asthma mimics. And surprisingly, in this paper, they didn't include COPD, so I've stuck that over there. And I think that's a really important asthma mimic, because you will get airway obstruction. It is an airways disease, and you'll get periods where the airways get worse and more inflamed during exacerbation. So you'll get a drop in lung function. But obviously, it's a different disease because we don't use inhaled corticosteroids as a primary treatment for COPD. So CCF, I can certainly say a number of patients I've seen, I cannot count how many patients I've seen in hospital, have been prescribed bronchodilators for heart failure. And I can assure you they respond much better to furosemide than they do to bronchodilators. PE, look, I don't see that as a common one. CF, again, in Australia, it's very unusual to identify CF as a de novo presentation for asthma, although CFs do get asthma. BOOP, bronchiectasis, absolutely. Hypersensitivity pneumonitis, maybe. Reflux, I've seen a lot of reflux. Central airway obstruction, a few patients I've got with that, as well as extrathoracic extrathoracic obstruction, such as vocal cord dysfunction. I've got a few patients like that as well. So often asthma and reflux go in hand. So there's certainly good evidence to show that asthmatics have a higher rate of reflux than the baseline population. However, the reverse is not always true. Treating reflux in asthmatics does not consistently result in an improvement in asthma. So you can see down here the group studies, the meta-analysis studies, and you can see really there's no difference with treating asthmatics with or without reflux treatment versus a placebo. Although there is some in the peak expiratory flow, but there is some reduction in the degree of wheezing. So certainly, and I think it goes without saying, if someone's got uncontrolled reflux or has reflux, you should probably treat it with a PPI to reduce A, their level of discomfort, and B, reduce the risk of further complications like Barrett's esophagus. Other comorbidities that go hand in hand with asthma, certainly allergic rhinitis, and you can see me rubbing my nose as I've got a bit of hay fever at the moment, thanks to the silky oaks out at the moment. Obesity, and there's certainly a phenotype of female overweight young asthmatics where obesity is a strong driver of their uncontrolled asthma. Sleep apnea is associated, obviously smoking, but then you kind of like, is this COPD or is this asthma COPD overlap, or are we just driving airway inflammation without airway damage yet? Dust and allergen exposure, obviously that sort of fits up with the allergic rhinitis. All these comorbidities need to be optimized. So this is study 2, not study 1. Jo was another 28-year-old young lady. She was referred to me for frequent asthma symptoms. She was on high dose inhaled corticosteroids. So you can see now she was on 2 milligrams of daily fluticasone propionate, so a very high dose. For those that have attended my COPD inhaled corticosteroid talk, you'll recall that fluticasone propionate is associated with a 10% risk of pneumonia per year. And over 9 years, you have a 90% chance of giving someone community-acquired pneumonia. I suspect at 10 years, it would be 100%, but the study only ran for 9 years. So she was referred for frequent symptoms, and she was a teacher, which became important. So her chest was clear, but she had Ventolin with Richard prior to seeing me. Her heart was normal. She did have some congested nasal mucosa and particularly a hoarse voice. So you'll notice that she's on the Acuhaler 500 formulation. And what was the problem? Well, she wasn't using her device. Why wasn't she using her device all the time? Because it caused dysphonia, and because of dysphonia, she couldn't talk or yell at the children. So I changed to an MDI. I picked a less potent steroid because I was confident in what I was dealing with. We could see on the spirometry she did have bronchodilator reversibility, but she had that because she wasn't using her puffer. So I gave her Symbicort MDI virus spacer. I did start at a high dose, but then reduced the intensity, as I saw on serial appointments. I also treated her allergic rhinitis. So there's good evidence, again, just showing that treatment of active hay fever or allergic rhinitis with nasal steroids, as well as nasal douching, is associated with improved asthma control. So mometasone is my preferred drug, and she started off high potency and just using it twice daily initially, and then rapidly dropped down to once daily and then started spreading out as she had control of her hay fever. And she started using a puffer because she could talk and yell at the children. Even though she was rinsing her mouth out, oral hygiene just only treats the oral component of the steroid deposition. You can't wash out your larynx. And if you can, you probably need to see an ENT surgeon. So her problem was that she had the hoarse voice, so she wasn't using it, and therefore her asthma was out of control. So by simply changing her device, I managed to improve her. And I think also treating her hay fever improved her symptoms as well, because the postnasal drip was then controlled. Device usage is critically important, and I think that's probably the thing that I do the most is optimize devices. The simplest one is making sure the patient can trigger the devices. Little old ladies cannot trigger turbohalers. And then the second one, which is a little bit more tricky, is the patient using the device appropriately. And again, the classic is the patient using an MDI with a spacer. So in this particular compliance audit, they reviewed 182 patients at a difficult control asthma clinic in the UK. 35% of the patients had filled less than half the required number of scripts for a 6 month period. So a third of the patients weren't taking enough inhaler. Filling less than half the scripts was associated with a significant increase in the amount of Ventolin they were using, and a reduction in the need for hospitalization. Perhaps, again, unsurprisingly, if patients use their puffers, they do better. So I like looking this up every single time I do it, and I've got all the devices here. So turbohaler, and these are the errors that people make when demonstrating the turbohaler. They don't prime it properly. 50% of patients in this study of 2,000 patients did not prime it properly. They did not hold it vertical. They did not twist it until it clicked or turn it back to the original position. So that's 50% of patients aren't getting a dose out of a turbohaler. 35% don't have the chin tilted upwards. And I'm not sure how much that contributes, but it's one of the things that they've got to do. 30% of patients, 1 in 3 patients, don't have sufficient inspiratory effort to trigger the device. 25% of patients aren't breathing out. And look, I could keep on reading it down. There are a lot of other errors, but they're the major ones at the top. In the same study, the Acuhaler device, 40% of patients can't breathe in hard enough to trigger the device. Now, I don't know how many of you have tried the placebo devices or use an Acuhaler. There's not a lot of negative inspiratory pressure, but we're still looking at patients that are just not breathing in hard enough. Don't breathe out first. Again, 30% of patients. 25%, no breath hold. And I won't belabor the point, but you can see all the different kind of problems that patients have made along the way. I hope you appreciate me making my own meme, but obviously the most important thing with an MDI is to use it with a spacer. So without a spacer, only about 7% of the drug will get into your lungs, and there are various studies that say different numbers. This is the one I will quote, and 70% with a spacer. So MDI serotype, 50% don't have a good enough slow, deep inspiratory effort. 35% prepare the second dose incorrectly. So they're on 2 puffs twice daily, they're not getting it right. 30% don't do their breath hold. 25% don't breathe out. 25% don't breathe at the right time with the device, and so on. These are major errors. These patients aren't getting drug into their lung. Education of puffers is critical. Every asthmatic should have their inhaler technique checked at every appointment. We do that. Well, when I say we, I'm very spoiled. I have a nurse that does that for me. But I suspect a lot of you have clinic nurses as well, and they could certainly be doing inhaler checks for you. When I start a patient remotely on a new device, I'll write to the chemist, please educate them on device, on the script, and make sure they use it with a spacer. So I've just said that these patients weren't using the devices properly. What does this result in? Well, this is a univariate analysis between inhaler errors and uncontrolled asthma. And you can see here, basically, patients weren't opening the caps. You know, unsurprisingly, that's significantly associated with a poor control. 4 times greater chance of poor control of uncontrolled, odds ratio for uncontrolled asthma. Insufficient inspiratory effort, 1.3 to 1.7 times chance. No breath hold, 1.5 to 2-fold chance of poorly controlled asthma. And MDI serotype, you know, breathing out before you breathing out through the device. There's all sorts of errors that result in poor control. You need to make sure your patients are using their puffer first for uncontrolled asthma. That is the most critical thing. What about obesity? So obesity is an independent risk factor for the development of asthma. And there is a dose relationship. So the more obese you are, or the greater your BMI category, the more likely your asthma control is poor. So here we've got, in this particular study, they looked at between normal, overweight, and obese patients, and the asthma severity. You can see that normal patients have intermittent and mild asthma, overweight patients have mild to moderate asthma, and obese patients have moderate to severe persistent asthma. And they're self-rated. You can see sort of the line as it goes down here from the self-rating of their asthma control. The normal patients have good control. The overweight patients have good to moderate control, and the obese patients have partly moderate control and poorly controlled asthma. In this particular study, this looks at the odds ratio for overweight men and women. I think that was, yeah, overweight is the top graph and obese is the bottom graph. And they looked at the chance of identifying asthma 1 year after the diagnosis of obesity was made. And you can see that there's a significant increase in the odd ratio. So 1.4 chance of identifying asthma in overweight individuals, and nearly 2-fold increased risk of identifying asthma in obese individuals. It is a different phenotype, as I alluded to. It tends to be a late onset. Females more, a lack of A to B, low airway nitric oxide pheno, which is a new test we're offering at the base lab. And when you look at the kind of inflammation driving their airway, it is not eosinophilic inflammation, it tends to be neutrophilic inflammation. And it tends to be less responsive to steroids. And in those patients, I might consider using azithromycin or a LAMA, because LAMAs treat COPD-style airway inflammation better. And I hope I've got enough time. Yep, looking good so far. So obesity and asthma. So the mechanism is quite complicated. And look, actually, I regret putting this in, so I might just skip it over. So what do you do? Well, you still have to treat it like asthma because you've got the airway inflammation. So you're mainly using the inhaled corticosteroid. You probably add a LABA, and then early on, rather than going down the airway, the monoclonal treatments, I would add in a LABA much earlier on, or as I said, azithromycin. In this particular study, they got patients to lose weight. So they had a very low calorie diet, and as I'm sure many of you have read in my letters, I'm a big proponent of very low calorie diets. Intensive phase optifast is a phrase that I use often. And they got patients to lose 14 kilograms, so a not insignificant amount of weight loss. They had them, not there yet, and they managed to maintain 11 kilograms of weight loss, and they demonstrated an improvement in the peak expiratory flow, the FEV1, and the forced vital capacity, and these all were sustained at 1 year. With surgical weight loss and falling from supermorbid obesity with a BMI of 41 to just morbidly obese, there was a significant improvement in breathlessness, although you do wonder how much of the breathlessness is because I'm just carrying around less weight, but also a significant reduction in rescue inhaler usage. Interestingly, and I did not know this, but there's the study down there, Theophylline is contraindicated in obesity and asthma because there's an increased risk of exacerbation. So in genuine severe diagnosis of asthma, what do we have? We've got a true diagnosis of asthma, so we're treating the right disease. Their comorbidities have actively managed, reflux, obesity, hay fever, whatever it needs to be. They're using their puffers properly, and they're on the right device, right puffers for their device. You've got a little old lady, she is not going to be triggering her turbohaler, put her on an MDI and spacer. And in fact, I would argue that any difficult to control asthma, the first step is to put them on an MDI with a spacer because you're getting better airway deposition. There are now multiple monoclonal antibodies, dupilumab, mepolizumab, benralizumab, which I spelt wrong, I apologize, omalizumab, which is anti-IgE, and they basically demonstrate there's a reduction in exacerbations and oral corticosteroid usage, and there's less evidence for improvement in lung function, but they definitely work. However, I'm not going to talk much more about that because if they get to that point, I'm definitely seeing them, but you guys have already managed up here. So if I'm seeing them, then that's where we should be at. You guys can manage most of the asthma up until then. So make the correct diagnosis at the outset. Get them to do spirometry. Now, whether you get them to do that in your office or whether you send them out to Richard and we can organize to have them do spirometry in the body box, and we do pheno testing and we can write a little report for you. I don't care, but make sure you do the diagnosis of asthma. Just like you wouldn't start someone on prendipril until you check their blood pressure, don't start someone on an inhaler until you prove you know what you're treating. Select the correct device for the patient. What is their physical ability? What is the side effect profile of the device? And what device are they likely to use? I've said Brio, inhaled corticosteroid, fluticasone furoate, increased risk of community-acquired pneumonia. But if a patient's only going to use a puffer once a day, then that's probably a better device for them. Treat their comorbidities, and then if it remains difficult to control, please send them along to see us. Thank you.
Thank you very much, Charles. We might move on now. We'll have any questions that are directed to your presentation at the end of our education session tonight. So our next speaker is Dr. KV Singh. KV is a staff respiratory specialist at Orange Health Service, and he has an interest in respiratory conditions like lung cancer, interstitial lung disease. He's commenced dedicated respiratory clinics, including a weekly fast-track lung cancer clinic, and has restarted diagnostic and therapeutic bronchoscopy and introduced an endobronchial ultrasound service at Orange Health Service for investigations of lung cancer patients who would have previously had to travel to Sydney for these tests. And KV is going to be speaking to us about lung cancer, early screening and diagnosis. Thank you very much, KV.
Hi, so KV Singh, a respiratory specialist, Orange. So I'm talking about the early detection and management of lung cancer. So most of the lung cancer, the art is to find them early and manage them early, because we know the more we detect in early stages, the better the prognosis is. So I'm going to start with a case presentation. So this is the case I actually saw myself when I was in training, and it just stuck with me. So a 57-year-old female presented with shortness of breath, cough, wheeze for 5 weeks, a few episodes of hemoptysis. And she had 3 courses of antibiotics, steroids, and inhalers were started in the community without much significant improvement. She didn't have past medical history, however, she was a current smoker of 35 a day for 40 years. And she was very breathless and wheezy. She was aparaxial, however, hemodynamically a bit hypertensive and tachypneic. She had a quite oxygen requirement, and she had this inspiratory wheeze. So I'll put in inverted commas as because you'll see. So this was her chest X-ray. So she had a couple of chest X-ray done in the community, and they were all similar looking. This was her X-ray when she presented to hospital. Doesn't look very exciting, so we'll come back to it. So she was diagnosed at exacerbation of newly diagnosed COPD, started on nebulizers, hydrocortisone, antibiotics, and there was a question mark whether she had a stridor or upper airway obstruction. So ENT guys came along and saw her and looked at her vocal cords and everything, that didn't think there was any upper airway obstruction. And she actually started feeling better by then. I think probably the hydrocortisone and helped a bit. But then she deteriorated overnight, quite wheezy, breathless, went into respiratory failure with hypercapnia. She was transferred to respiratory ward for NIV support, and noted that she had an obvious stridor and seesaw breathing, which you get if you got an upper airway obstruction. So she was intubated, and the plan to do a CT scan and bronchoscopy. So this is what her CT scan showed. So quite large mass in the mediastinum with narrowing of the both main bronchi and the lower end of trachea. This is from another angles. And this is what she looked endobronchially. So infiltrating tumor in the lower end of trachea and bilateral main bronchus narrowing to that extent. So this is how easily, like Charles mentioned, the mimics, and very important to diagnose them properly. But if you go back to her chest X-ray, I think it's very hard to see that mass. So I'm going to talk about early detection and management of lung cancer. So we talk about the incidence of lung cancer, mortality related to lung cancer, some guidelines, some evidence, screening studies, and lung cancer pathway. So what's the incidence of lung cancer? So as per Cancer Australia, in 2020, there will be over 13,000 new cases of lung cancer. And in 2021, the new numbers are around 13,800. So the numbers are increasing every year. So lung cancer is the 5th most common diagnosis of cancer. So 1 in 5 cancers is a lung cancer, and is a leading cause of death from cancer. So most cancer deaths happen in lung cancer compared to any other cancer. So in 2020, 8,500 deaths caused by the lung cancer. So that accounts to one in 5 deaths from all cancers. And the survival from lung cancer is quite poor. So 5-year survival rates around 18.6% compared to all cancers combined, which accounts to 69.2%. So it's a serious disease, and with a very poor survival, and we can change that if we can diagnose them early. So just a couple of graphs to show the same thing. So this is from Cancer Australia. The estimated number of new cancer diagnosed in 2020. So the lung cancer is 5th in all of those cancers, and the deaths, estimated deaths, is number 1. So this figure shows the mortality. So how the mortality varies between different areas, regional areas, and socioeconomic status. So the major cities, the mortality is slightly less compared to the more remote you go, and the more remoteness is one of the associated with high mortality. So again, the socioeconomic status, as the socioeconomic status decreases, the mortality increases. So that comes into importance when we're looking at how to detect lung cancer or where we should be spending our resources. So again, we know that the smoking is the single most important factor causing lung cancer. So all these incidences of lung cancer and mortality relates closely to smoking status. So this again, the slides demonstrate that the incidence of smoking with the socioeconomic status. So the lower quintile has the highest smoking status numbers compared to the higher quintile. So again, there's a major difference between indigenous and non-indigenous population. So almost a double the smoking incidence in indigenous population. And it has remained, although the smoking incidence is going down, but the difference is still remaining the same. So this is the smoking related to remoteness. So major cities, less people are smoking compared to people living in the remote areas. Now, incidence of lung cancer. So why it's important, basically, in looking at the indigenous population and non-indigenous population. So if you look at the incidence of lung cancer, it's again higher in indigenous population compared to non-indigenous. And if you look at the curves, they looks like they're presenting or they have lung cancer earlier compared to the non-indigenous population. So again, mortality follows the same trend. Now, one of the important thing about looking at the all other cancers and lung cancer is the people present late. So if you look at this table, say 42% of the people, they present in stage 4 lung cancer. And the other thing to mention is that 28%, it was unknown because it's not documented. So we don't know how many of these were at stage 4 at the time of presentation. So major chunk of people, they present when it's already too late. So we can't do much. And we know the stage 4 prognosis is very poor. And the survival, 5-year survival is very, very poor. So compared to other cancers like melanoma, 78% of the people present early. Breast cancer, almost half of the people, they present early, or you diagnose them in early stages, and also colorectal. I think the major thing is because we got screening programs for all these things. So that's what makes a huge difference in presentation. So this is the lung cancer incidence and survival. So if you detect people in stage 1, your survival is much better, which is the lighter bar, compared to how many people we are detecting in that stage for lung cancer. So very few people are getting detected in stage 1, but we know that the survival is much better. So compared to stage 4, where 50% of the people or more probably getting detected at this moment in time. So what are the efforts made to improve the early detection of lung cancer? So there has been a lot of randomized controlled trial all over the world. The US took the lead, and they've done a lot more studies, and they got quite important studies which came out and making the basis for lung cancer screening worldwide. So different methods have been looked at. What's the optimal way of screening people, whether chest X-ray, sputum cytology, low-dose CT scans. So a lot of different studies done, and the best modality of detection of lung cancer is at the moment is preferred low-dose CT scan. From all these studies, what have we learned so far? So there's nowhere in the world at the moment they started widespread or lung cancer screening at the moment. So, but there's lots of lessons learned so far from these studies. So we learned from all these studies that how to manage small pulmonary nodules, and all those nodule guidelines came out from those. So we know that the CT can detect early stage lung cancers. We know that the excellent survival in majority of screened patients. So the Lung Cancer Australia published the data where they say the people who get diagnosed in the screening, they have like in breast cancer, they have 50% improved survival. People who get diagnosed colorectal cancer, they have 70% improved survival compared to incidental finding or symptomatic when they are late. So we know that excellent survival from this screening. Now we got more epidemiological studies or data from these studies. And we know that more adenocarcinoma we can pick up from these studies. And there's always this question of overdiagnosis and whether we're doing more for the slow-growing tumors, which might not cause trouble, especially in elderly population, where sometimes we just end up watching them as and treat them symptomatically. So the age-old question, the radiation dose. So this is a slide comparing the radiation dose with a low-dose CT scan. So it's 10 to 14 times worse than chest X-ray. However, compared to a diagnostic CT, is much less. And a lot of these people who are smokers who are symptomatic, they end up having some sort of CT at some point. So low-dose CT is still low risk compared to what most people end up having for these things. So randomized controlled trials. So there are various different trials, but the most prominent are the Nelson trial, which was Dutch-Belgian trial. It included 15,000 participants, and they had the CT scan interval at 0, 1 year, and 3 year versus no screening. And they included participants which were active or formal smokers at the age of 50 to 75 years old. Most of the US evidence comes from this national lung screening trial, which was the major trial with 50,000 participants were included in this trial. So individuals at risk, they identified age between 55 to 80, smoking history of at least 30 pack years, the current smoker or quit within 15 years. And they found from their trial that there's a 20% reduction in mortality from lung cancer with annual screening with low-dose CT scan. And they found the 6.7% reduction in all-cause mortality in low-dose CT scanning group. So national lung screening trial. So there were some uncertainties. There was high false positive rates. There was variability in follow-up protocols for these patients. They weren't 100% sure the target population, what to target, and there was some uncertainties because they used a 1 year interval, whereas the Dutch screening, they use a different intervals, and the cost effectiveness, which is another very important thing to look at. And they also looked at they were wondering what is going to have an effect on a screening versus smoking cessation, or be diverting our resources when we could be preventing people developing cancer, because we know that smoking is the most important single factor which can cause lung cancer. The potential benefit of screening with the CT. So NLST found that 20% reduction in lung cancer mortality and significant reduction in all-cause mortality. European trials, again, they were on the similar page. Nelson trial showed they used volumetric analysis for nodules, and they suggested early CT for follow-up nodules to determine the size. So that's where the nodule protocols and stuff were followed up or originated. So there's ongoing research on risk reduction tools and biomarkers, and the best target for people, low-dose CT scan. So what are the potential harms of screening patients? So low-dose CT scan had a high false positive in a national lung screening trial. I think they rated up to 18% of the people, they had a false positive rate, and then that led to potentially invasive procedures and potential harms with the risk associated. Again, the concerns about radiation dose, which we know that is higher than chest X-ray, however, much less than the diagnostic CT. The estimated cancer deaths related to the radiation, so 2,500 people, one cancer death related to exposing 2,500 patients to the CT scans. So potential for harm as a result of anxiety associated with positive results or false positive results or false negative results, giving them reassurance. So all these assess the potential harms with the screening. So limited data on overdiagnosis rates of low-dose CT scan. So estimated 18.5%, like I mentioned earlier, from this trial. So studies on screening with the chest X-ray, we know that they say high overdiagnosis rate of 25%. So low-dose CT is definitely better than chest X-ray. And they found that there was no evidence that the smoking cessation is affected by low-dose CT scanning. And it wasn't evident that the smokers are falsely reassured with a negative scan. So where do we go from here? So lung cancer screening in Australia. So the Queensland lung cancer screening into investigating the feasibility of a low-dose CT scan screening in Australia published the initial findings, showing the magnitude of benefit was similar to the national lung screening trial. So in August 2019, the Honourable Greg Hunt MP requested Cancer Australia to conduct an inquiry into prospect, process and delivery of National Lung Cancer Screening Program in Australia. So this was one of the major steps, I think, taken to progress in this field. And they asked Cancer Australia to produce this report, which is, I'll go through over the next few slides. I think it's a landmark in this field. So this is the report on lung cancer screening inquiry. And so few points from that. So they came out with this framework, how the screening will work in Australia and what other policies needs to be set up for this. So population cohort, so most important thing, so general population age 55 to 74 years, and Aboriginal and Torres Strait Island 50 to 74 years current or former smokers. So we knew from those graphs that the Aboriginal and Torres Strait Island, they have a early age the lung cancer onset. So that's why the difference in age group. Now the risk assessment, so compared to other screening trials, so there has to be robust risk assessment, otherwise you will include more and more people and false negative or false positive percentage will go up. So Australia supposed to, or as per this report, they suggested using PLCOM 2012 risk prediction tool, which is a modified risk prediction tool based on a large trial from USA, which P stands for prostate, L for lung, C for colorectal, and O for ovarian cancer trial, which publishes data in 2006. And the US, they used a similar risk prediction tool. And for Australia, they recommended that we should use this tool. And if someone's got 6-year risk score of more than 1.51%, they should be included into the screening. And risk assessment should be taken by authorized health professionals so that you can correlate this data. So screening eligible population, again, the age groups, as we know, based on the PLCOM risk predictor model. Entry point, how people will be entered into this screening program. So either they can be self-referred, facilitated entry with person recommended by the health professional, opportunistic entry where recommended during a routine consultation, or organized entry where you look at the data or from the various health networks and you invite people for screening. Screening interval, so they looked at what's the optimal screening interval. So they chose the low-dose CT scan every 2 years is more feasible. If you increase the frequency, then the cost associated is increased. Screening interval infrastructure, so they suggested to use public and private partnership and possibly mobile scanners hard to reach areas, as we know that those are the places where the highest mortality and high incidence of lung cancers. So low dose CT reporting. So this is to address the fact of the high false positive or high false negative rate and what to do with an abnormal scan. So they suggested a structured reporting by radiologists and computer-aided detection, and then a second radiologist to review the results. And they suggested a pan-can nodule management protocol, like the Brock model. And they suggested for the nodule management, the modified lung RADS 1.1 nodule management protocols for subsequent scans of incidentally detected nodules or opacities or changes. And they suggested that all the scans should be uploaded to a screening register, and the scan reports should be provided to GP and participants. So again, even the mobile services, they should be reported centrally rather than peripherally. So there should be a virtual diagnostic hub. So screening intervention assessment. So depending on the scan, so you offer them interventions. So either they go and continue the follow-up scan if it's stable, or people with a high risk or suspicious, they should be referred to specialists linked to the MDT for further investigations. And results of the lung investigation, lung nodule investigations from the lung screening, they should be registered in the screening register. Participant, so they suggest a policy of reminding participant of the screen for further screening. And what happens when they reach the age of 75? So they can be offered a validation screening in older people when they reach the age of 75. When they've been through the screening. So screening register they suggested to maintain so that we can look at the data collection and we can share and evaluate the data. And the principles of screening they suggested the value-based, agile, accessible, person-centered, evidence-based, and research data. So there has to be some governance around the screening program. So they suggested with the centralized data and looking at the data and constantly trying to improve the service. So this was a framework provided by the Cancer Australia on the basis of that inquiry. So how different people fit into this framework? So at the recruitment phase, so different takers can come into the play: primary care nurses, GPs, Aboriginal Torres Strait liaison officer, quitline counsellors. Then you decide on the eligibility of people for screening. Then you start screening where the radiographer, radiologists, and physicists come in. And then you do assessment with the reporting, and then assessment with the physicians or GPs. And then the next part goes on to the management if you find something abnormal. So all the different specialties or healthcare providers which could take part in this screening. So this is just a structure around a quality and safety framework, so governance, so how it can contribute to the governance of the program. Now, this is just a condensed version of how the screening can look like. So you identify a person who's going to enter the screening. You risk assess them with the PLCO M2012, and then you either advise them on smoking cessation if they're low risk, or you include them into low-dose CT scan program. And then depending on the findings on the CT scan, then you progress through this. So if they haven't got any significant finding, they move on to a 2-year CT scan until they finish the program, or we find anything, any significant abnormality on subsequent scans. Now, based on the lung RADS, if they had a low malignancy risk, then they go on to 12-month CT scan. And again, depending on if there's an interval growth, whether they go back into 2-year screening, or they get referred to a specialist. If they got moderate risk, then they go on to 3-month low-dose CT scan. Again, depending on their risk, they move on to either seeing a respiratory or the specialist associated with the lung MDT, or they go back into the screening or 12-month CT. And anyone who's got high risk of malignancy based on the CT scan, they get directly referred to specialist associated with the lung cancer MDT. So incidental findings, then they suggested how we're going to manage the incidental finding as per guidelines and refer to the appropriate specialist from there on. So this is like a snapshot of what the lung screening can look like in Australia. So as per last month, Lung Cancer Australia, they're looking into implementation of the lung cancer screening. So they're looking at the various participants who are going to come on board, like the public-private partnership, and the program of recruitment of all these partners. So they got 12 months to do that. So hopefully, not in distant future, maybe a year or maybe a little later, we might see the lung cancer screening started in Australia. So this is going to be the world first lung cancer screening for general public. So there has been lung cancer screenings done as a group or localized areas, even in different countries. But this is going to be the world's first generalized lung cancer screening in the world when it starts. So where can we intervene in the lung cancer? So we know that we need to intervene early. We need to diagnose lung cancer patients early. So we got optimal care pathway for people with a lung cancer, which suggests that the time to treatment from referral should be less than 42 days. So it shouldn't be no more than 42 days. So that includes the first referral from GP, seeing a specialist who can do the diagnosis, and then discussing in multidisciplinary meeting and start of the first treatment. So it should be no more than 42 days. That includes the surgery. I think it's difficult with the Australia setup because we got such a remote areas, and for the surgery they have to travel to major hospitals, Sydney or other specific areas, which can sometimes lead to the delay. But this is the ideal pathway where people should be treated within 42 days, and the quicker you treat, the better it is. Now, we know that the urgent referral pathways for suspected lung cancer are associated with reduction in mortality. So there has been studies done in the past with looking at these pathways, and that's where the urgent referral pathway or the fast track pathway for lung cancer are available on all different sites in Western New South Wales. This is another interesting study which said 23% of all patients first attended a hospital emergency department previously, described the lung cancer symptoms, which one acted on. So again, looking at the mimics, and we know that if we vigilant, we can pick people early and diagnose them early. And most patients will have had 3 or more consultations before they see a specialist. So again, this is another study looking at presentation. So being vigilant, finding people early, but that's where the lung cancer screening will come in. So identifying the high risk people and enrolling them into, so that we can bypass these caveats. The other important thing from the various studies is that referral to a low volume non-cancer specialist had an impact on likelihood of patient not receiving treatment. So that's again very important, which Cancer Australia mentioned in their report, that they should be referred to a specialist associated with lung cancer MDT. So what we did in Western New South Wales from Orange a few years ago was this roadmap trial, where we it's a referral decision prompt, where we had a phase 2 randomized controlled trial. So any abnormal CT scan report had a paragraph at the end saying that if any suspected cancer should be referred to a specialist associated with lung cancer MDT, and there was contact numbers for respiratory specialist and a lung cancer or cancer specialist nurse on there, so the GPs can directly or promptly refer this patient on to the lung cancer. So the idea was whether we can reduce the delay between CT scans and especially seeing the patient or referrals. To get the best benefit of that, we had a lung cancer clinic set up, and the idea was to see patient within 1 week if possible, but not more than 2 weeks in a specialist clinic from GP referral, and then start investigation and refer on for management depending on their diagnosis. 42 days from GP referral to commencement, that's the cancer care pathway, and that's again Cancer Australia stressing on that. And the patients are first referred to a specialist linked to multidisciplinary team, MDT, lung cancer MDT. So that's where we are. I think the major thing is going to be when the screening starts, and the quicker we can diagnose patients through the screening, we're trying to move the diagnosis or the staging towards the stage 1 disease, where compared to every other cancer, we only diagnosing people in stage 1 disease, 11% of the people in stage 1 disease. So the lung cancer screening, they're suggesting with the implementation of lung cancer screening, we should be able to, or we should be aiming to diagnose 70% of the people in early stages, so that we can offer them curative treatment. So thank you, everyone.
Thanks very much, KV. I'm sure there'll be some questions for you at the end of our program. Right now, we're going to move on to a presentation on sleep studies by Dr. Henry Ainge-Allen. Henry's a staff specialist at Double Base Hospital. He and Charles are colleagues. He maintains a close association with the Woolcock Institute of Medical Research and the Respiratory Failure Service at Royal Prince Alfred Hospital. And it's with them that he had completed his clinical sleep fellowship. Henry has a keen interest in research and medical education. So thank you very much, Henry.
Hi, everyone. I hope you can all hear me. Thanks, Kerry, for that great talk. So when I initially thought up this particular topic, I was hoping that we would have a public sleep lab running and operational at Double Base Hospital, but COVID seems to put a bit of a pin on that. So at the moment, we're still relying on the existing services, but hopefully that will change in the next few years. The title of this talk is a comment I hear on close to a daily basis, working as a sleep physician. In terms of what I'll try and cover during the talk, really it's focusing on who to refer for a sleep study, when you need to involve a sleep physician, and specifically who can safely be managed with limited specialist involvement, and digging a bit deeper into sleep apnea and the driving implications as well. So the first case to try and illustrate this is a 64-year-old farmer. His BMI is 36. He's got your usual bag of comorbidities, and he describes a fairly classical history for apnea, sort of with witnessed and symptomatic nocturnal choking episodes, which frighten his wife, and waking unrefreshed in the morning. He is excessively somnolent during the day, with an ESS of 14, and using the stop bang, which is one of several tools available to categorize risk. He is someone who would be high risk for sleep apnea. Despite that, on question, he says he's had no somnolence while driving or other features to suggest high risk driving. He's got normal oxygen saturations. So after seeing this patient, would you then immediately refer on to a sleep physician, or request a sleep study, or do both? I mean, the answer is it depends on your level of interest in the condition. Certainly you're able to refer for a diagnostic sleep study at this point. He meets the updated medical criteria for a referral, being at least moderately somnolent with an epilepsy score well and truly over 8, and being sufficiently high risk based off one or more of the various questionnaires that help us determine pretest probability of having sleep apnea. Now, most of the sleep apnea referral forms that are out there these days will have questionnaires on them for you to fill. Certainly you don't need to do all of them, but if you want to order a sleep study, you will need to do at least the Epworth and one of the others. Now, there are a lot of patients with significant sleep apnea who'll be missed by this. And for those in whom you still suspect apnea, despite not meeting those criteria, they should all be referred on to see myself or any of us really. And we can then request the study. In terms of what I look for before requesting a sleep study, and this is by no means an exhaustive list, anyone who's reporting excessive daytime somnolence, symptomatic or witnessed apneas, a higher risk occupation such as a truck driver, where there's other risk factors present, such as an elevated BMI, which is basically all of them, and a family history of sleep apnea with some of the above. This is just to sort of remind you all of what we actually see on a sleep study in a fairly stylized representation. You can see here true obstructive apneas, which are really part of that spectrum of sleep disorder breathing, ranging from simple snoring, which isn't generally considered pathological, all the way to obesity hyperventilation, which carries a 20% mortality at 2 years untreated. What you can see is there's essentially repetitive episodes of complete collapse of cessation of airflow during sleep with ongoing respiratory effort, and that's due to collapse of the airway, usually at the level of the pharynx. Now, this leads to hypoxemia and arousal from sleep, which then restores that airway patency. And it can happen hundreds of times throughout the night. And importantly, for those of you who are interested, significant upper airway obstruction can occur in the absence of complete airway collapse. So that increased airway resistance can result in a measurable reduction in airflow and a reduction in oxygen saturation, as well as plus or minus an arousal, and that would label a hypopnea, which gives us apnea-hypopnea index, which is simply the combination of either of those events over the average number of hours slept. So mild sleep apnea is an AHI of 5 to 15, that apnea-hypopnea index, with symptoms of sleep apnea. So if someone comes to you or you've sent someone for a sleep study and the AHI is, say, 10, but they're not actually reporting any symptoms of sleep apnea or excessive daytime somnolence, but you referred them perhaps because they were a truck driver, that person is still technically within the range of normality and does not have the obstructive sleep apnea syndrome, whereas anyone who has more than that 15 does meet that criteria. And that's just sort of recapping that there are two entities, one being the obstructive sleep apnea syndrome, which previously included within its definition excessive daytime somnolence, regardless of the severity of the obstructive sleep apnea, but now encompasses both of those groups. Now, what about those patients you get who on attempting to refer them for a sleep study and mentioning the potential implications for their driving, which I'm always inclined to do, well, and they don't want to go ahead, well, if they're truly excessively somnolent, so with an Epworth sleeping score of 16 or above, or they have any history of motor vehicle accident caused by inattention or sleepiness, or they're reporting sleepiness while driving, then the medical advice to not drive holds, even if they decline investigation of probable obstructive sleep apnea, which then has obviously implications for them as they're the primary responsible person for notifying roads and motor services. This is just some more data on the role of sleepiness itself. Focusing on, it's a study of 229 consecutive patients who were referred to a sleep apnea clinic in Spain. And you can see here, I'm not sure if my mouse is showing up, but the somnolent drivers were significantly more likely to have an accident on the road than the non-somnolent drivers, and it was a much more significant risk factor than AHI itself. Now, importantly, in a sleep clinic, we have an enriched population. Patients are referred to me because they're sleepy. So if you look at patients in a sleep apnea clinic, 90% of those with sleep apnea will have significant somnolence, but the population data doesn't bear that out. So this is the data from the Hypno-Louse study, which was a population study in Switzerland, of 2,121 participants in Lausanne. Now, only a third to a quarter of the patients with sleep disordered breathing had significant somnolence. And there was no specific correlation between the severity of their sleep apnea and the relative prevalence of their somnolence. So many of the patients that you see on a day-to-day basis who you suspect sleep apnea, but they're not somnolent, they could still have significant sleep apnea despite that. This is a rather frightening heat map of the prevalence of obstructive sleep apnea. And it comes from a meta-analysis of the worldwide population-based studies, which were quite high quality. And what they determined is that the overall prevalence of OSA is such that it ranges in men from 13 to 33%, and in women from 6 to 19%. Now, I suspect that the Dubbo population, even if we were to be blindly optimistic, would be certainly at the higher end of that range based on other similar populations. And unfortunately, I don't think I and Charles and KV can see a quarter of the adult population in Dubbo on an annual basis. But it is important to deal with the sleep apnea because there are consequences beyond the daytime sleepiness. There are significant cardiovascular impacts. There's a recognized impact on mortality, and importantly, as we've mentioned, driving safety. It's also, I suspect, although we haven't yet seen it in the data, important to treat patients early. A lot of the time, people come to our attention in their 50s and 60s, and by that time, I suspect there's been quite a lot of cardiac remodeling, and a lot of the time they're already in atrial fibrillation or they've had a myocardial infarction, and they're coming to medical attention as a result of observed sleep apnea in that setting. And in that sense, the horse is really already bolted. Going back to our case, our fellow who was sent for a home diagnostic study, there being up until recently no sort of viable alternative, and still no viable alternative in Dubbo. Now, and that showed that he has severe sleep apnea. So his apnea-hypopnea index is 54 events per hour, severe being over 30, and his oxygen saturation index, which is a measure of another measure of severity, being 36. But he's not spending a lot of time with very low oxygen saturations, and there's no sustained hypoxemia, which would be included within any report that you receive. from a credible sleep physician. The advice being the standard one that I feel like they just have printed at the bottom, being return to physician and consider CPAP. Now, some sleep study providers will offer patients CPAP at the time of this diagnosis, but it is still considered best practice to wait for a prescription from a medical practitioner. Certainly, however, if I were to receive a referral with this particular sleep study showing severe sleep apnea, I would attempt to see that patient a lot more swiftly than I would simply being referred a person who was somnolent. So it can actually result in them being seen more quickly within our services. But what is CPAP? I mean, I feel like it's probably being done a bit to death. As you know, it's a device to deliver air at a high enough pressure to overcome that upper airway obstruction that's occurring in OSA. What you may or may not be aware of is that the devices now come in two different settings. There's the oh, apologies. That's so it seems to have deleted. So essentially, they come in as fixed pressure, which where the machine delivers a set pressure that has been predetermined to overcome that upper airway obstruction. There's also auto set devices. Apologize, that's been deleted. So in these devices, the machine uses an algorithm to determine how much pressure needs to be delivered with every breath in order to overcome that upper airway obstruction. So often they'll be at quite a low pressure for much of the night, then when the patient rolls onto their back or goes into REM sleep where there's more muscle paralysis, then they'll deliver that higher pressure. There's no particular benefit between either device. Some patients report fixed pressure devices are more comfortable. Others report auto set devices are. The auto set devices are certainly on average a bit more expensive, but the benefit is that they are to a degree set and forget. So they will continue to deliver pressure within those parameters, even if there's significant changes in apnea severity over time. So in terms of the need for specialist input with our fellow, well, you may well need a CPAP script. And that, although that's something that you could potentially do if you're interested, that's certainly something that we would be more than happy to be involved in. But also potentially flags to suggest referring him earlier. If he has a resting oxygen saturation less than 94%, which this fellow doesn't, then that would suggest potentially there's a higher risk of obesity hyperventilation syndrome. If there was evidence on his sleep study of sustained nocturnal oxygen desaturation, or he was particularly overweight or with a significant comorbidity, then those would all be flags to refer on to us. Of course, if there are difficulties with treatment or there are any issues with affordability, then we can be involved at that level. In New South Wales, we obviously use Enable to supply CPAP devices for those who are not financially able to purchase them privately. But there is a means test for that. So if someone is able to purchase their own device without undergoing any significant financial hardship, then it's often the best path because Enable will assess that. Additionally, if someone is on CPAP for longer than a month and has significant residual somnolence, then there may well be something else going on, often medication or other features, and the sleep physician should be involved at that stage. Additionally, as this is almost certainly the case in most farmers, if they're on a commercial license, then the sleep physician is required to be involved by law. And you can see here, this is just from anyone on a private license, their sleep apnea can be signed off by a treating doctor. Doesn't have to be a specialist in sleep disorders. Whereas for anyone on a commercial license, they're held to a higher standard because of the increased risk, and they all need to see sleep physicians or respiratory physicians long term. And why is that? Well, commercial drivers are statistically more likely to be involved in accidents, they're more likely to be fatal, and they're potentially involved in the transport of dangerous substances. This data comes from the 2004 Australian study that was done out of the Woolcock. And looking specifically at commercial drivers, they interviewed 2,079 commercial drivers at close to 100 truck stops around Australia. And you can see here that of them, a large proportion of those who had accidents were extremely somnolent, and there is a bit of a trend there which becomes much more pronounced with the truly excessively somnolent with an ESS of greater than 18. Now, interestingly, of the 200 odd out of the 2,000 who agreed to undergo a full sleep study, roughly half had significant sleep disordered breathing. This slide comes from a 2009 meta-analysis of the available studies that used a cohort design to assess driving safety in sleep apnea. And essentially, as you can see, the OSA greatly increases your risk of crashing. That was shown in basically every single study that they looked at. CPAP does reduce the risk of accidents, but you need to use it. Non-adherent to CPAP in this particular study of 567 patients with a follow-up of roughly 3.5 years showed that those without good CPAP compliance had a much higher risk of an accident. And with that, I'll move on to the second case. This is a not uncommon referral that I get. It's a 76-year-old woman. She's retired. She had a diagnosis of sleep apnea through her chemist 8 years ago, but she's adherent to her CPAP and she's not somnolent. And she's attending because she wants her license renewed. Now, in this setting, in order to give a appropriate clearance for sleep apnea, you do need to obtain a CPAP download. And these will be obtained typically by the CPAP supplier or CPAP technician, often where they bought the device, or there are a few around Dubbo and Orange who do that, as well as, and Bathurst, of course, in some of the smaller towns they do visit. Provided a person is utilising their CPAP with a day's use greater than 4 hours of ideally 80%, but typically I'll accept sort of 70%, then I'm generally happy to sign off on their license. And that's consistent with most other respiratory and sleep physicians. You can see here that this patient, when she did, at the direction of her doctor, go to the CPAP technician, had a significant leak and a residual AHI. But this was in the setting of a slightly torn mask. So the mask was replaced and the CPAP technician had plans to review the patient in a month. CPAP maintenance is something that we don't performed. So it's performed by the CPAP suppliers. As much as I would like to think that sleep physicians are the center of the sleep apnea universe, it's often actually more important for patients to go and have their machines serviced and reviewed by a technician than it is for them to see us. We still need to get involved if, as mentioned, there's persistent somnolence despite CPAP, or if after a bit of tinkering, the CPAP techs are not able to get that AHI under control, or if there's any other issues really. But the first port of call should always be, in these long users who are having some issues, the CPAP technicians, because they're the ones who will make the change. We can identify the problems, but we don't provide new masks, and we don't service the machines. The next case is sort of a bit more towards the severer end of the spectrum. 55-year-old male truck driver with BMI of 54, who lives alone and therefore has no one to tell him that he snores or stops breathing during his sleep. Current smoker with a resting oxygen saturation of 91%. And there are really three things here which stand out to me as this being a gentleman who I'd want to see sooner rather than later. The resting oxygen saturation being the main one. So if that's included in a referral, then I would always endeavour to see that person quickly, because it shows that they're at risk of obesity hyperventilation syndrome, which I'll come to in a little bit more detail in a second. He's of course still someone who could be referred to a sleep study at the time of that initial review, but I would definitely send off a referral to a sleep physician at the same time as organising that. When he saw the sleep physician, they organised an arterial blood gas which confirmed the presence of daytime resting hypercapnia, which was chronic in nature. A sleep study confirmed severe obstructive sleep apnea with sustained periods of hypoxemia. So that's basically where your oxygen saturation doesn't recover after an apneic event. And these are much more challenging patients to manage than your run-of-the-mill OSA. So obesity hyperventilation is essentially defined as daytime hypercapnia, the resting PCO2 greater than 45 when well. They will almost all have a resting oxygen saturation less than 94%, typically less than 93 or lower. To meet the definition, their BMI needs to be over 30, but the vast majority of them will have a BMI greater than 40, and will unfortunately have a 20% mortality at 2 years if left untreated, though it is a somewhat challenging condition to study longitudinally. Part of the reason why we're trying to establish a sleep lab at Dubbo. Ideally, they would be studied in laboratory, but it's simply not practical in our region to do that at the moment. Finally, I'd just like to cover another type of patient who I'd see. 32-year-old woman who's unemployed, not overweight. Partner says she doesn't snore, but she's unable to sleep with daytime fatigue. Going through a detailed run of the time she spends in bed. It's highly variable. She'll take up to 1.5 hours to fall asleep. She wakes between 1 and 2 times a night, between 2 and 4 a.m., taking up to 2 hours to fall back to sleep, before rising variably between 7 and 9 a.m., and taking a 1 to 2 hour nap during the day because of her daytime fatigue and somnolence. Now, This woman clearly has insomnia. She has evidence of both sleep initiation and sleep maintenance insomnia, and evidence of compromised daytime function. Importantly, a sleep study is not required to make this diagnosis. And if anything, if you do try and put these patients through a sleep study, they'll generally struggle to sleep with all of the kit on. The management is, of course, bed restriction, behavioural changes, giving away that nap in the middle of the day for start, and also for the more severe cases, cognitive behavioural therapy for insomnia, which is, although not offered locally by anyone who I've been able to find, certainly offered online, free for anyone with a Medicare card at thisway.org.au. And of course, treatment of any intercurrent mental illness is essential. This is just a short and non-exhaustive list of the non-respiratory sleep that both myself or the other sleep physician in Orange would be more than happy to see, including patients with insomnia, RLS, any evidence of narcolepsy, although often that's diagnosed through MAC, or some sleep-wake phase disorders. So in summary, sleep apnea is common. The GP referral pathway for sleep studies does not capture all high-risk individuals. Patients on private licenses with good control of their sleep apnea can be managed without ongoing specialist input, provided they've got good links with CPAP technicians. CPAP is not always sufficient in severe disease such as obesity hyperventilation syndrome, but that's something that I would be heavily involved in. And of course, we don't just look after sleep apnea, although it might seem that way sometimes. Thank you.
Thanks very much, Henry. So, yeah, thank you to all of the presenters tonight, Charles, KV and Henry. We're up to the stage of the evening where we're going to have an interactive Q&A panel. We have a few questions in our question box right now, but if anyone has further questions, please just pop them in. So, look, I might start with two questions, both from Tony Brown here in Dubbo. And Tony's asking a first question about whether this will be more to KV, I think, whether there's thought of screening occupational cohorts in Australia for lung cancer, for example, asbestos or chromium workers.
I think that's an interesting thought. So the caveat to the lung cancer screening program or the report they mentioned is they mainly including in PLCO's score is the smoking history. There's some stress to the diagnosis of COPD or previous cancer and stuff, but they haven't included the occupational component because the number of people going through that pathway will be low. So this is going to be generalizable screening. But there's a option. So where we say opportunistic screening, where the physician sees a patient and considers them at high risk. So they might be able to include those patients into the screening pathway. So I think it's going to be more of an opportunistic identifying these people and adding them into, even though they might not fit through the or they might not be picked up through the usual pathway.
Thanks very much, KV. And Tony's second question is, if it's important to treat lung cancer very promptly, how confident can we be in a negative low-dose CT screen?
Negative low-dose CT screen is very good. CT is the ideal way of detecting lung cancer. So unless it's very tiny nodule, very early detection is difficult. So the guidelines they follow with the lung rad has got very clear guidelines on what stage of nodule you need to do further investigations. So anything below 8 millimeter, 6 to 8 millimeter, is considered as a low risk, but you still follow them up as per the usual guidelines. So if there's no abnormality, that means a negative CT, that is as good as it can get. So I think it's very reassuring if there's a negative CT, and they're going to be a very specific protocol which has to be followed up, and again cross-checked with a second person. So for my understanding, the negative CT basically rules out an active lung cancer or worrying lung cancer.
Thanks very much, KV. Look, right now, I don't see any further questions in the question box. So while people are thinking about questions, I was wondering, Charles, whether you could tell us about the test done in the lab related to nitrous oxide. I got a report back today that included that, and I thought, I really don't know about this, so this is my chance to ask.
You're muted, Charles.
Like all meetings, I start muted and then start talking. So FeNO stands for faucet-tailed nitric oxide. It's a particular, when they first noticed it was in airway inflammation, it was driven by eosinophils, and the eosinophils were noted to be release nitrous oxide. And so this particular test just measures the degree of nitrous oxide in the exhaled air. And there's good demonstration that correlates with the degree of airway inflammation. So the more eosinophils in the airway, the more reactive they are for asthma, the higher the FeNO content. And what it's really useful for is titrating, less about the diagnosis, although it does give you hints, because you also see it go up in pulmonary hypertension, in smokers, eosinophilic pneumonia, and a variety of other conditions. But once you've got the diagnosis of asthma, it's really good for down titrating your FeNO, down titrating your inhaled corticosteroid. So I'm an asthmatic, and my FeNO is about 5 last time I did it. So hopefully that means I'm well controlled. And so that means I've actually down titrated myself on my level of inhaled corticosteroid down to the lowest dose inhaler I can get my hands on. So that's what it's useful for, is in managing asthma and knowing that the patient is on a sufficient dose of inhaled corticosteroid, or in fact the reverse is that we can reduce the dose of inhaled corticosteroid to reduce the risk of harm from the inhaler.
Fantastic, thanks. And Charles, another point that you made was the importance of checking our patients using their devices appropriately. Is this a situation where the respiratory outpatients clinic can help us, or respiratory rehab?
Yeah, absolutely. Either of them can help. So you can make a referral and we can check the technique and the inspiratory capacity. So Ange, my nurse, does that in clinics for Henry and I, and Maria in pulmonary rehab can help organise that for the outpatient services as well.
Fantastic, thank you.
I'm going to volunteer them for that. I hope they don't mind.
Sorry, I missed that.
I said I volunteered them for that. I hope they don't mind.
Yeah, they're pretty motivated.
There are a lot of devices and a lot of different ones to learn how to use, but the Lung Foundation website also has on it short videos on how to use all the devices. And I don't know if any drug reps are online tonight, but I think Menarini has QR codes on their puffer poster, and then if you scan that one, you get an app, and then if you then point the camera at the different puffers, it brings up the Lung Foundation website and the technique to use that puffer.
Fantastic, it's pretty amazing. And Henry, to you, until we have our sleep study lab in Dubbo, if we have patients who we feel should have sleep studies, I was just wondering what your recommendation is in terms of referring them out of town or versus, say, the home sleep study. I was just wondering yeah, what your thoughts about that, your recommendations?
The home sleep studies, the level 2 studies. Basically the ones that do everything but the video monitoring or close to are pretty good. If anything, there's a slight chance they'll underestimate the severity of the sleep apnea. They'll almost never overestimate it. Certainly what I do is refer patients for home sleep studies at the moment. Medicare's pushing us more towards doing that as well. So to actually get an in-laboratory study, you need to tick a couple of extra boxes because they're that much more expensive for Medicare. So I think home sleep studies will be a part of our practice even once we do have a proper laboratory, and they're almost always sufficient. You know, the number of times where we then would refer on for an in-lab study is actually quite small.
That's great. And did I hear it correctly?
Just to be on that, they do need to be the slightly more complex level 2 studies. So the ones you can get from the chemist where you just put your, you know, wear something on your wrist, they will miss over a third of sleep apnea. Yeah.
Right. And could I just clarify, people using a CPAP device need to have that serviced approximately 6 monthly?
Oh, look, that's the official party line, but I think every year at least. Basically, they need to, if they can change their own filter, then every year at least it should be downloaded and looked at by the sleep technician, who can make sure that it's all doing the right thing.
Yeah, that's fantastic. Yeah. I'm just noticing what we have on our screen now. We've got someone's desktop in their email list. It's probably not what we're wanting to have. Yes. Okay. Well, Charles, KV and Henry, I want to thank you very much for a really informative session. Our participants, and there have been quite a few of them, have been a bit shy with their questions. There are no more in our question box. So I thank you again and ask our participants if they would use this QR code and their mobile phones to evaluate this session. So yeah, on behalf of everyone, thanks to the three of you, and it's been a really good evening. Thank you. And I think we
Thank you very much.
We close right now. Thank you.
Thank you.
Thank you all so much.